Okay, so now we are going to look at anesthetic agents that are used in IV form and their different aspects like doses, their formula, chemical names, and what precautions measures should we take before giving these IV agents. So, introduction is these IV agents, IV anesthetic drugs are propofol, thiopentolate, ketamine, etomidate, benzodiazepines, in which most commonly used midazolam, and dexmedetomidine. Their chemical structures are like these, and this is not very important. This is important thing that propofol has emulsion milky white color. Its concentration is 1 to 2%. So concentration and lipid solubility only emulsion form. It is insoluble in water. And another one is ketamine is clear aqueous solution. It is very lipid soluble. Another one is benzodiazepines like midazolam is clear solution and a lipid soluble. Propofol needs emulsifying agent, like there are different percentage of propofol. So and ketamine is racemic mixture of isomers. Okay, metabolism of propofol. Metabolism of propofol is occurs in the liver, and then from liver it is excreted into the kidney, and then in it metabolites happen. And the same is for ketamine, same is for benzodiazepines, same is for thiopentone. So these are metabolized by liver. Any liver dysfunction can impair the metabolism of these medications, IV anesthetic agents. Now function, which is very important, propofol has a function of selective modulator GABA A receptor agonist. When GABA A is agonized, increased calcium influx will be there, and then there will be prevention of generation of impulse. So this is the thing that you have to keep in mind. Ketamine is non-competitive binding phenylcyclidine NMDA receptors, weak action on the GABA. It dissociates thalamus from limbic system, and movement is prevented along with analgesia. And it is also used in depression, untreated depressions. And the benzodiazepines act bind with the GABA receptor, increase frequency of opening of the chloride channel, and causes hyperpolarization. So in this way these drugs have agents. Now there is a different mechanism for these drugs. Propofol decrease intracranial pressure and decrease intraocular pressure, and it has no role in dissociative anesthesia, emergence, or does not cause nystagmus and does not cause salivation. While ketamine increase intracranial pressure along with intraocular pressure, it causes dissociative anesthesia, emergence reaction is there with nystagmus is there, skeletal muscle tone is increased, and lacrimation or salivation can be increased with the ketamine. So this is the thing that you have to keep in the mind. Next one is propofol is antioxidant properties, reduce infarct size when administered for ischemic insult. And then ketamine has evolution of alpha rhythm, once onset of delta activity is there, and produce burst suppression at high dose. Okay, propofol decreases 20 to 40% of blood pressure, so you have to give it cautiously with the patient having hypotension, and it inhibits tachycardia response, and then uh, response to the hypotension, and may cause bradycardia and decrease cardiac output. So you have to give it with the patient and with the monitoring of blood pressure. And then ketamine increases blood pressure, it increases heart rate, and it increases cardiac output. So ketamine also given with the patient having cardiac problems. You have to give very importantly. Benzodiazepines also decrease blood pressures like midazolam. It increases heart rate and decreases cardiac output. So you have to take care of the patient, especially having cardiac problem. Propofol causes apnea along with if a large dose of ketamine is given, they cause apnea. And then okay, now induction doses of propofol is 1 to 2.5 mg per kg, and ketamine is 0.5 to 2 mg per kg, and maintenance dose for propofol is 50 microgram, and for ketamine there is 0.5 to 1 milligram per kg, and the analgesia is, and for analgesia we do not give propofol. For analgesia we can give uh, ketamine, and there is also anti-emetic dose of propofol as well, which is not very important. We can use metoclopramide for anti-emetic properties during surgery. Now propofol has interaction with fentanyl, and we have to take care of that thing very carefully. And then propofol is used for induction, sedation, and maintenance as well. It can be used as anti-emetic or anti-pyretic medications. And then we use ketamine for analgesia, preemptive analgesia, and then benzodiazepine we can use while induction or maintenance and sedation as well. Side effect of propofol is pain, hypotension, and then allergic reaction can be there, thrombophlebitis or tolerance can be there. Propofol and decrease neutrophil function, while ketamine has activity of emergency treatment or hangover effect or tolerance can be there if given in excessive quantity. And benzodiazepines have immunosuppression properties, while there is no any other important aspect of side effect. Now propofol can cause bacterial infection, hypertriglyceridemia, and pulmonary embolism. Propofol infusion syndrome is lactic acidosis can be there, which have to be taken care. And then there is a ketamine, which is emergence delirium. Symptom will be visual, auditory, proprioceptive, and confusion illusions will be there. Ketamine induced depression of inferior colliculus, and that results into all of these type of side effects. So it was the all about different IV anesthetic agents that have different functions and different